So this repeating this same video, so I went on doing a capsulorhexis in this cases, and we did a phaco chop in this case, and slowly you have to be very meticulous, put in your high viscoelasticity and go about to do the chop. And finally, when you are taking out the last piece, be careful enough so that the PC doesn't come in into the play, and you will be good enough to take out all the cortical matter. Either you use a bimanual or a coaxial, and then do the PC polishing, and then you can put in a acrylic hydrophobic lens into the bag. So there are other various techniques how to manage the capsulorhexis. You can do a two-stage capsulorhexis which keep on teaching. So you do a smaller rhexis and then extend it to make it a bigger rhexis. You can use your phaco prof, do the nick, aspirate all the cortical matter. You can keep on doing a frequent aspiration of the liquefied cortical matter. But what Dr. Titial had described in one of his literature, you can use the femtolasers in these cases, and you can have a good capsulorhexis. So most important is the deciding factor to have a free floating capsulorhexis is to see that you don't have the gush of the milky fluid which is coming out, and you have to always assess the microadhesions which is there, and you take your capsulorhexis forceps and complete your rhexis in these cases. So after doing that, I'm going to show you. You are good enough, you have finished your case, and you have done an adequate capsulorhexis. But in this case, this is a 52-year-old man who is having a diabetic. So this case was the density of the cataract was quite dense. So be minimal hydrodissection you have to do, don't rotate much. Be careful because you don't know how much is the posterior pressure in these cases, and in this cases what is happening because of that leathery type of cataract, I was not getting the full trench in each of the cases. But be meticulous, be slow. You can chop it how much is possible, take part and part of it, and you will be good enough to complete it with a slow process and use viscoelastics in these cases. And the best thing is you will be not having a clear cornea the next day. You can also see in this type of hard cataract on white cataracts. So incidence of capsulorhexis related complication is a posterior capsular rent, vitreous loss, or a nucleus drop. And density of the nucleus in with a hard cataract, there is a risk for the corneal endothelial trauma. And if your white cataract is associated with a small pupil, then you have to use the hooks in those cases and pupil expanders. If a PXF, you should always keep handy with the CTR and all. If it's a traumatic white cataract, well, you have to assess the situation and go ahead. So most important thing is while performing the rhexis, use sufficient high molecular weight viscoelastics, be gentle with your hydrodissection, mobilize the nucleus when you are giving hydrodissection so that you can release this posterior pressure, which and then phaco chop is ideal. So my take home message is always be pre-operatively make sure that is there a fluid from the decompensated lens proteins within the bag, that is, are you seeing the interlenticular or the convexity of the anterior capsule, which is a intumescent cataract where you will have a runaway rhexis. Is the nucleus dense or relatively soft? Are there any other associated abnormalities? So this meticulous preoperative evaluation, good surgical planning will give you a success in most of the cases. Thank you.
Thank you, ma'am, for a wonderful presentation and good surgical videos. How do you deal with intumescent cataracts wherein you can't every time do CCC consistently?
So in most of the cases, you start with a smaller rhexis, that is what usually 2 to 3 millimeter, 3 millimeter, you just don't plan to have a full 5 millimeter. So most important when you are making the nick, that is the thing, make a smaller nick, always use your capsular rhexis forces, make it smaller, and after that you have done it, and then you again extend it and make it a bigger. If it is like 3-4 millimeter, you are good enough to soft cataract, you do it. You can put the intraocular lens in the bag and then again do an adequate rhexis. Important thing that the IOL is covering all the ages, that is the capsular rhexis.
Sir, what is your opinion about things that people do like punchorhexis or doing, because you had a paper with femtosecond assisted. rexes?
I think Dr. Rajendra Prasad will cover that also in difficult cases. We all understand, you have to differentiate, different types of white cataract. And you rightly pointed out what Dr. Kulkarni was saying. It is the intumescent white cataract where you'll have more chances of rexus getting uncontrolled and maybe towards the periphery also. There, with the examination, you can realize which type of intumescent we have. Sometimes you can aspirate with the needle. People go directly with the 26 gauge needle and aspirate. And some people do a small rexis, as Dr. Sucheta was telling, then aspirate, then complete your rexis. Some people do a puncturexis, which is also direct puncture to which may be little uncontrolled, except for Dr. Mohan Rajan, who can do very well. Then Dr. Rajendra Prasad, who has described a very nice swing needle punctures, multiple small puncture, which is a circular puncture, so the run gets extended as it is. So those various things are there which can be done. Most important words he talked about is a good examination of patient. If you realize what type of a white cataract you have, then accordingly you can do it. But if you have a anti-segment OCT, that gives a good picturization of morphology, then you can create different.
So basically it is the intralenticular pressure which is very high. So you need to increase the pressure in the anterior chamber to flatten the anterior capsule
These
so
high
that
viscoelastics.
the extension to the periphery, the risk is
Doesn't-
reduced. And if you make a smaller rexis, initially you can use a micro scissors and then use a micro forceps to enlarge the rexis also. And another thing is usually if there's a fluid that has a less propensity to go to the periphery rather than the swollen cortical fibers. There the propensity to go outside is more.
Thank you.
Compromised at any point. If you feel that the patient's cooperation or the patient has started wincing and not cooperating, then without compromising on that, we can only go ahead.
Now the patients have started demanding also no injection surgery. So in that case, the comfort level and the confidence of the surgeon actually is the most important factor.
Yeah, so a good microscope with good visibility and good red glow will
Everything
help
has to
faster
be-
surgery. Definitely.
Thank you.
Thank you.
Wonderful
Very
skill,
nice
sir.
talk.
Thank you.
Thank you.
Thank you very much. Now we go to the next presentation, that is on our phaco and white cataracts. We'd like to invite Professor Dr. Sucheta Parija. She is head of department in AIIMS Bhubaneswar. Where is she? So she's going to take us through the difficult scenario of cataract surgery, that too in a white cataracts. I hope that in Odisha we have more of white cataracts, either SICS or a phaco.
So good afternoon to you all and respected chairperson and dignitaries. I'll be talking on phacoemulsification and white cataract. I have no financial interest in this presentation. So in the OPD, when we are sitting and seeing all types of cataracts and we cannot name not all white cataracts are the same. If you look into the cataract, you see the first cataract which I am showing you, it's not painted with trypan blue, it's a cataract which is having a bluish hue. You go into detail and see the next cataract, you'll see the anterior capsule is fibrosed in these cases. You'll get cases with a white cataract where the cornea scar is there and you know it is a traumatic cataract. Go in and you'll be seeing next cataracts, you'll see a yellowish hue or the cortex is liquefied in these cases and more into the Morgagnan cataract. So spectrum of white cataract are there, and Bragitikos et al. Have classified it as type 1, type 2 and type 3. So main challenge we have when we are actually dealing with the intumescent white cataract with cortex liquefaction. Anterior segment OCT also helps you to look for the subcapsular clefts in the white cataract as described by Danny and all. But if you are good enough and have a eye OCT with you, which will be guiding you to see exactly the interlenticular clefts and you will be actually helping you out to do your capsulorhexis as described by Tetial et al. So what are the surgical challenges? I'll be talking about the two main things, that is how we are going to handle the capsulorhexis and the nucleus management. So main is the difficulty in creating an intact adequate size capsule, and we see that 3.8% to 28.3% we don't have a complete rhexis in those cases, and nucleus hardness also to assess it is difficult because we don't have a red glow. There is a weak and flaccid posterior capsule and absence of the epinucleus. So your technique which to be used and what complications can occur should be already made. So what are the challenges you have? So once you are seeing this type of intumescent cataract where the anterior capsule is bulged, there is a convexity, and once you go in and just give a nick, you'll see the milky fluid which is coming out, and then there is a chance of extension and you can have the most dreaded complication, that is the runaway rhexis or a Argentine flag sign. So let's look at this case. This is a 52-year-old male who came to us. It's a white cataract. We are staining it, and I was lucky enough because the anterior capsule was fragile and we didn't have those milky fluid which was coming out. So we usually used the capsular rhexis, went ahead, and after doing done a capsular rhexis, what exactly, the cataract was not very hard, so we went ahead and did a multi-quadrant chopping in these cases, and slowly we could take out each of this capsule, and finally, so let me complete. So be slow, that is what is enough is you keep enough of your trypan blue, be slow, assess each step, give high viscoelastics, and you can